The thyroid is a very big topic. It's a very important topic. And the thyroid's not very forgiving. There's a lot of things in the environment that can impact how your thyroid's functioning, and thyroiditis, specifically Hashimoto's thyroiditis, which is a so-called autoimmune condition, is one of the most prevalent conditions experienced by women. And we know that it's prevalent because we screen a lot of women for thyroid dysfunction because of the importance of thyroid hormones for your developing baby. The issue that you may have already encountered if you found our program after going to a number of doctors and midwives and maybe you've had pregnancies in the past is that we in the allopathic system have really no idea what we're doing when it comes to the thyroid health. And this is what a thyroid, I guess, looks like, by the way. It sits right here above your voice box. It's this little gland, two wings, kind of like a butterfly shape. The purpose of the thyroid in general is to keep your engine on idle. It's actually a little analogy that I took from Tom Cowan. I want to give him credit. It keeps the engine on idle so that if you run into the store and then you run back out, you can just ramp it up, crank it up, and drive off. You don't want it to turn off because you want to keep the engine hot, right? Let's say you have a battery issue or something like that. But you don't want the engine idling in the red zone. You just want it to be hanging out there. The thyroid determines how many RPMs is your engine, just plugging away at when you have it on idle and you're not accelerating and you're not braking. So in pregnancy, it's very, very active. It gets bigger, about 30% bigger throughout your pregnancy. And during the first 12 weeks, the high levels of that beta HCG that's produced by your placenta will stimulate TSH receptors on the thyroid. TSH normally comes from the brain, but we have HCG that acts a lot like TSH, and that hits your thyroid, and that causes an increase in the production of what's called T4, thyroid hormone. That's thyroxine. And through the negative feedback loops, again, everything is connected. It goes to the brain and says, hey, we don't need any more TSH. There's a lot of T4 around. And the brain's like, well, I haven't been sending TSH. Where's it coming from? It's coming from the placenta. So this negative feedback loop actually can mess with your thyroid studies when you check it early in pregnancy because there's so much HCG circulating. There's also, due to the high amounts of estrogen early in pregnancy, there's an increase in protein that binds up your thyroid hormone from the liver. And so the total amount of thyroid hormones circulating is increased dramatically during your pregnancy. In the third trimester, TSH increases as the placenta is growing, okay? The production of deiodinase, which is a primary enzyme that is required to produce thyroid hormone, also increases. So there's a lot of activity here, and as I said, it's not very forgiving because any superactive tissue has a greater chance of failing you. So what does the thyroid hormone do? It hits, and we're going to talk about this, but what we're talking about here is actually not T4, which is produced from the thyroid. It's predominantly T3 that has activity in the body, and it acts everywhere. T4 has to be converted to T3, which is going to be a big part of our discussion later. But first, let's just bear in mind the thyroid is active everywhere in the brain. It makes it more in the heart. It makes your cardiac tissue more sensitive to the catecholamines that will increase your heart rate. Those catecholamines include epinephrine and norepinephrine from your adrenal glands. Everything is connected. It stimulates respiratory centers in the blood. In the lungs and blood vessels in the lung tissue in order to improve oxygenation or to improve the diffusion of oxygen from your airways into your blood. Although even that concept I sort of question, because why is oxygen preferentially passing over and not nitrogen and argon and all these other gases that are present in our environment? Just something to bear in mind. There's a really interesting paper. I can actually provide it to you if you reach out to me, and it really discusses, is it actually oxygen that is diffusing in the lungs, or is it electrons that are being passed over? Both very, very reasonable hypotheses. That paper happens to be written by Gerald Pollack, who's a very, very gifted scientist and a very good problem solver, let's just say. Thyroid acts on the skeletal muscles and increase your fast twitch muscle fibers. making for very, very much stronger contractions and strength. And this works alongside growth hormone. Everything is connected. It works at the bones to improve your bone density. It increases your metabolism by increasing aerobic respiration, which is an oxygen-consuming process in your mitochondria. It also works to break down fat and carbs, and it supports the building up of proteins. So when your thyroid's working well, your body has more lean body mass. You have more energy throughout the day. Your bones are stronger. Your heart works a little more efficiently. Your lungs are a little bit more efficient. And then for the fetus and for the child, we need the thyroid hormone to be present in optimal amounts in order to develop the nervous system and to support the development of the brain. So the thyroid hormone is critical for keeping you and your baby healthy throughout the pregnancy, into postpartum, and really for the rest of your life. So what I was describing here, when you have a lot of estrogen, you get increased thyroid binding globulin, which decreases the amount of available thyroid hormones, which tells the brain make more TSH. The TSH goes to the thyroid, and you get increased thyroid production. HCG is also hitting the thyroid and telling it to make more thyroid hormone. The arrow from HCG over to the brain isn't listed here, but there's a feedback there as well. There's a lot going on here. And by the way, notice down here, ovarian hyperstimulation. This is when you get to the fertility clinic and they start pumping you filled with chemicals. It causes an increase in estrogen, an increase in TBG, and can result in thyroid dysfunction. So the less external inputs into this very complicated dance, and this is super simplified, the less inputs, the better. So as we mentioned, the HCG from your placenta will hit the thyroid and tell the thyroid to make T4. And that T4 is as abundant now, as well as T3. They feed back to the hypothalamus and pituitary and say, we don't need any more thyroid hormone, thyroid. We got it. You've done your job, so we're not going to send any more TSH. But that signal is still coming from HCG. So as a consequence of this activation of the thyroid by HCG, you get an increase in T4. A lot of that gets converted to T3, so you're going to see an increase in both of those numbers if you get labs. But there's also going to be a decrease in the TSH through negative feedback. And sometimes your OBGYN will be just treating based on the TSH, which is a problem for reasons that we're going to clarify here. So the most common form of thyroid, let me say that most of your thyroid hormone in circulation is T4, and that's thyroxine. A lot gets converted to the active form, T3. And this is another means of checks and balances as to how much active hormone do we have circulating. Triiodothyronine is T3. And by the way, you can get medications, pharmaceuticals that have exclusively T4 and some that have exclusive T3. But us OBGYNs like to only use Synthroid, which is only T4, which is a big problem, and we'll get to that in a second. There's also the possibility of creating what's called reverse T3. So T4 can become either active form T3 or it can become reverse T3, which is also inactive. And there are situations in which, like inflammatory issues, autoimmune issues, some really, really severe gut dysbiosis, acute illness, and even pregnancy, I believe, that can lead to an increase in the amount of reverse T3, which is not helpful. But it also does feed back to the brain. Like I said, there's various conditions in which this can happen. What we think is during all of those conditions that I mentioned, like the acute illness and whatnot, it's that this mechanism of converting some T3 some T4 instead of to its active form, but rather than its active form to this reverse T3, that this is a means of preserving energy. That idling, when your car's on idle, is still burning through energy. So when thyroid hormone is doing its thing, it's actually getting fuel from various tissues, fat, liver, muscle, wherever it can find it, in order for you to have enough fuel in order to drive aerobic respiration in your mitochondria. And so if you have a lot of that going on, a lot of people who have hyperthyroidism are jittery, they have trouble sleeping, they're always hot. It's because their furnace is being stoked, they're redlining it all the time, and that requires energy. So as a means of preserving energy, like in acute illness, for example, you will have, and also fasting, by the way, you'll have an increase in reverse T3, which is a means of preserving you. Nature doesn't make mistakes as far as I'm aware. So this hypothesis I actually think is quite compelling. But honestly, I had never even heard of reverse T3 until I completed all of my functional medicine training. So I have oysters here. I'm going to keep bringing them up. I'm actually eating them as we speak. I took a little break while I'm recording, so I'm not noshing here while I'm talking. But in order for your thyroid to be working really, really well, you have to have adequate protein, fatty acids, iodine, selenium. If you're a vegan, one of the first things I'm going to wonder is about how is your thyroid working? So all of those things, iodine, selenium, fatty acids, protein, they're all abundantly found in nature's multivitamins, specifically oysters and other bivalves, but man, oysters take the cake. So if you have some degree of thyroid dysfunction, you can become tired easily, you may be losing hair, kind of pathognomically, the outer 1/3 of your eyebrows, lack of motivation, depression, anxiety, sleep disturbances, electrolyte imbalances, cardiovascular disease, a myriad of issues related to pregnancy. A lot of this is actually related to the hypothyroidism, which is far more common than hyperthyroidism. But you can see, gosh, just how important this is. And let me go back a couple slides. People say birth control's benign, blah, blah, blah. Well, birth control also does what ovarian hyperstimulation does. It leads to hyperestrogenism. You're taking estrogen. And then that estrogen, interestingly, when you take your pill, let's say, it goes into the intestines, it gets absorbed in the blood, it passes through the liver, and you get an increase in thyroid binding globulin, in sex hormone binding globulin, and a lot of proteins that bind up active hormones. Meaning that when you come off of birth control, you might be left with thyroid dysfunction that we now need to fix in order for you to have a healthy pregnancy. So when they say it doesn't impact your fertility, they're full of it. Like, there's no way around it. The other thing I'll mention, I wanted to go back to say that, the other thing I'll mention is that depression and anxiety are commonly, very, very commonly, the vast majority of women end up with a mood disturbance. That's the way it's described in the literature. As a consequence of being on specifically combined oral contraception for a long period of time. Thyroid dysfunction is associated with that as well. So is it the birth control that's causing that? Indirectly, yeah. Indirectly, yes. Not to mention that there's also, the vast majority of your serotonin, which is considered like the happy molecule. That's what antidepressants are meant to fix. Most of your serotonin lives in the gut, and the birth control pills themselves, not only do they mess with your thyroid through the mechanisms we've described, but it also damages the gut by throwing your microbiome out of whack, and that leads to a lot of the depressive and anxiety disorders that are so closely associated to birth control pills. But they're safe, they're fine, don't worry about it. No big deal. Blood clots for some people, but hey. I mean, it's a little bit, it sounds a little bit crazy. So the fetus will begin making its own thyroid hormones. I mean, you've got a fully formed fetus roughly at 13 weeks. Now, of course, it's still growing, and of course, you're still developing, and tissues are still figuring themselves out. But until the 10-week mark, the fetus is relying on mom's thyroid hormones. So T4, that's the inactive form that gets converted to the active T3 form. It can go across the placenta throughout the pregnancy. It's converted and utilized in the fetus, specifically in the brain, for this entire 10 to 13 week period before the fetal thyroid gland takes over this role. So this is the first trimester is always the most important trimester from the standpoint of nourishment and how your baby's growing. Looks like this is a copy of that previous slide, unless I went backwards. So let's get back into this reverse T3 thing, which actually does happen to be, I think, associated with pregnancy. Like, your body's trying to conserve energy, right? At least conserve your own energy. If I see this really, really elevated in pregnancy, I'm still thinking that there might be something else going on. But because the theory that conserving energy in pregnancy, if the purpose of this is to conserve energy, you really don't want to be doing that in pregnancy, because your baby is like voraciously consuming fuel. But it does happen, and I think it may be that if you have way more reverse T3 than we would like in your pregnancy, it may be due to any of these steps that we're about to talk about. So there's different deiodinase enzymes, which are important for these conversions. And T4 will become T3 whenever under the influence of deiodinase 1 and 2. And then T3 will do its job, and then it'll become inactivated by deiodinase 3. Well, we want you to have way more D1 and D2 in operation than D3, because we really want T3 to be produced preferentially. In some women or some people, D3 is preferentially active, and you actually get a conversion of T4 to reverse T3 in those people. So this is, don't hark too much on this. I just want you to appreciate that there's not just deiodinase, there's multiple types, and whichever of those enzymes is most active, you're going to get either of these pathways taking precedence preferentially. So let's talk about hyperthyroidism for a second, because the majority of what women experience is hypothyroidism. And of course, if you have a lot of thyroid hormone, it seems like that would be a good thing. That's between hypo and hyperthyroidism. Hyper is going to be far more dangerous. Usually this is due to Graves' disease, and on labs it's going to show a high T4, high T3, and a low TSH. 95% of hyperthyroidism is due to Graves', which is where you have antibodies that stimulate the thyroid gland. That's at least what they say. And the nervousness, the tremors, the palpitations, hypertension, excessive sweating, frequent stools, heat intolerance, all of that, and then the buggy eyes. So everything is ramped up. Your body's like jacked up on Mountain Dew. If it's untreated in pregnancy, all of these issues, preterm birth, miscarriage, fetal demise, fetal tachycardia, poor fetal growth, preeclampsia, maternal heart failure, thyroid storm, all of this stuff needs to be considered. There's a really, really good reason to be treated if you have hyperthyroidism. Hypothyroidism is when we have too low of T4 and T3, and consequently a high TSH due to the lack of feedback inhibition to the brain. As I mentioned, Hashimoto's thyroiditis is the most common cause in pregnancy, and this is thought to be due to antibodies that attack the thyroid glandular tissue through these anti-thyroid peroxidase antibodies. In Graves', those antibodies can cross over the placenta, and they can also impact the baby. In Hashimoto's, these antibodies don't cross. They're just too big or something. It's usually not related to poor iodine intake, at least in the United States, but I'm going to challenge that. Like, that's what the experts say. I'm going to challenge that in a little bit. If you have hypothyroidism, there's a lot of the same issues like pregnancy loss as hyperthyroidism. We need this to be just right, just warm enough. But of course, the fatigue, constipation, cold intolerance, hair loss that I've mentioned before, these are the hallmark signs of hypothyroidism. And of course, there's issues for the baby as well. So we mentioned a lot of these. It's interesting that a lot of these are the same as they were in hyperthyroidism. So we have to be very, very considerate as to how much thyroid hormone you have, and to not just be looking at TSH. So if the TSH is decreased, but you have normal thyroid hormones, we're not going to call this hyperthyroidism. We're going to say, you've got normal hormones, but that TSH signal is being suppressed. So this is subclinical hyperthyroidism, meaning you may develop hyperthyroidism, but right now you're good because you've got normal amounts of thyroid hormone. On the other hand, if you have increased TSH but normal thyroid hormones, we call this subclinical hypothyroidism. No treatment here necessarily, but we do anticipate that this could potentially be a problem that might just be sort of exposed during or after your pregnancy. When you have a decrease in TSH and increase in T4, we just call it what it is, hyperthyroidism, and this is the opposite for hypothyroidism. So when we have subclinical disease, there's no treatment warranted per the experts, as it doesn't seem to be associated with poor outcomes for mom or baby. However, it is associated with, outside of pregnancy, with abnormal menses, and if you're going to go the route of assisted reproductive technology, it's also associated with higher ART failure rates. The last thing I'll say is that it's unlikely that this will become overt disease rather than subclinical disease in your pregnancy. And so checking it every couple weeks doesn't really make sense. The only time we would be repeating the labs in pregnancy is if we've done something that we think will improve your numbers, like we start you on medication for hyperthyroidism or something like that. So a typical OBGYN is just going to get TSH screened in the first trimester, but as you've already learned, the TSH has to trigger the production of T4. T4 has to be converted to T3, not reverse T3. And then that actually has to have some effect on the tissues. So getting a TSH is not sufficient. My approach is to get a TSH, a free T3, a total T3, reverse T3, a free T4, get the anti-thyroid peroxidase antibodies, that's to screen for Hashimoto's, get thyroid stimulating antibodies, that's to screen for Graves', and get anti-thyroid globulin antibodies. One blood test, we do a very, very detailed clinical history, get a family history, get past pregnancy history, and then we kind of know. I don't always order this, but I will if I suspect anything on your history. Sometimes that actually is fine to just get a TSH. If you come into pregnancy though and you were like, I had that thyroid issue in the past, I'm going to get the whole panel. I also will get a whole panel if you have diabetes, if you have a history of miscarriage, if you have a history of preterm birth, placental abruption, small babies, or obviously any history of thyroid issues. Okay. If we detect antibodies, that can indicate to me as the doctor that you may have some issues with your thyroid postpartum, which is a really, really rough journey for the female body in trying to reestablish itself at a new center. So if we have any history or any reason to be really thoughtful about thyroid disease at any point in pregnancy or thereafter, it can be helpful to have this as a baseline, and then that'll help us optimize your postpartum care. So here's ACOG's rubric. If you get a TSH and it's normal, they say you're euthyroid. What if you have a normal TSH, but you have actually low T3, but normal T4? So bear in mind that T4, T3, and reverse T3 all can feed back to the brain in order to influence the level of TSH that's in your blood. If it's elevated, then we check free T4. If it's decreased, we check free T4 and total T3. I don't like this rubric, but this is what the docs do. And you can see if you end up with decreased TSH and you end up going down this path of hyperthyroidism, there are medications we can use in your pregnancy that will prevent your baby from having, being exposed to excessive thyroid hormone. And if you have hyperthyroidism and it's real deal, then we need to watch the fetal status closely, including growth. Women who have hyperthyroidism tend to lose weight, and your baby will as well. Too much thyroid hormone will be pulling too much of that fuel out of the fat stores and really the body mass of the baby. So these babies tend to be a little bit small. If you're having signs like elevated heart rate of hyperthyroidism, we can use beta blockers in order to get you through your pregnancy. Methimazole and propylthiouracil can both be used in pregnancy to decrease the amount of circulating thyroid hormone. Or I should say decrease the amount that's produced. These will cross the placenta. We don't use methimazole in the first trimester because it's associated with some fetal anomalies like esophageal or choanal atresia and aplasia cutis, which is a skin condition. The PTU, propylthiouracil, is fine, but it can be hepatotoxic, meaning toxic to the liver of mom. So we'll use that in the first trimester, and then we'll switch to methimazole later. We don't want to be using a hepatotoxic medication for the whole pregnancy, because then mom's liver enzymes and her liver function may be damaged. So treatment of hypothyroidism there's one principle: start low and go slow. You can use thyroid replacement hormone, and that comes in a variety of forms. Most commonly, you're going to hear, from a doctor or midwife, levothyroxine, but that is only T4 and it's synthetic, but it is very common and it's very easy to get. It's very, very cheap. When most people are going to be treating this, they're going to be using TSH as their sort of guideline. You want your TSH ideally between 0.5 and 2.5, but you might have a normal TSH, but actually kind of on the low end of normal, or even below a functional range of normal for T3, which is slightly different from what the doctors use. You can also use something called porcine thyroid hormone. The brand name is Armour Thyroid. It's natural. It comes from the glandular thyroid tissue of pigs. And that will have a little bit of T4, a little bit of T3, and it'll have some extra nutrients that are found in the glandular tissue. So anytime you add medication, I would repeat the labs in 4 to 6 weeks, ideally closer to 4 weeks, and then you adjust the dose as appropriate. And then if you're, let's say you're in the first trimester, we add medication, and now your numbers are great, we can just repeat it. We'll repeat it in 4 weeks. If it's still normal, we'll go to trimester by trimester, we can check it. If you have a lot of reverse T3, even in pregnancy, I would be really thoughtful about any sources of inflammation or illness. And that makes me think of the gut immediately. I'm not talking about viral illness. Yes, you can have changes if you're acutely sick. I don't see viruses as like a primary cause of human illness. I think that they have been blamed for a lot of human illness. I actually think it's more environmental, which is sort of evidenced by the fact that even during COVID, not everybody got sick. Why did a lot of people get sick? Why did people even with the vaccine get sick? There's just so much we don't know, and we'll go into that in some other lessons. We also have exclusive preparations of T3. I can't remember the name of it, but you can get, just like Synthroid has levothyroxine, which is synthetic T4, you can get a synthetic T3 specific medication as well. And that would be for somebody who, they have normal T4, but their TSH is, let's say, a little bit elevated. A part of what I'm thinking is, gosh, you've got plenty of T4, are you just not converting it to T3, right? That's why we need to get the whole thing. We can't just look at T4 and TSH. We also have to know how much of that T4 is actually being converted to T3. And if you only look at the total number, then you have a bunch that might be bound to TBG, that's thyroid binding globulin, TBG. And so the total number is not relevant either, because when thyroid hormone or any hormone is bound to a protein like TBG, it's not active. So we want to be very, very clear as to what labs we're ordering, why we're ordering in them, and then what we're going to do about it. There's a little reminder down here at the bottom that the fetal thyroid is not doing the full job of what the fetus needs until about 12 weeks. So that's on us to be making sure that mom has optimal thyroid hormone production, conversion, and activation at the tissue level, at least until 10 to 13 weeks, but ideally throughout their whole pregnancy and well into the rest of their life. So let's think about this from a functional lens. You have to synthesize T4, you have to convert T4 to T3, and then the cells in the various tissues we talked about have to be able to receive that signal. So there are specific thyroid hormone receptors on tissues that are, that's the lock, and the key is T3. So we can work with any of these, and in order to make enough thyroid hormone, you need plenty of tyrosine, iron, iodine, zinc. Goes back to the bivalves like oysters, beef livers really, really help for this. Even whitefish like cod, which has a lot of iodine, and other shellfish have lots of iodine. These can be super helpful. And this, I would be thinking about synthesis if your T4 and or T3 are suboptimal, meaning below where we want them, and TSH is either normal or high. In order to convert T4 to T3, you need a lot of selenium and zinc. So this is the scenario I described. T4 is maybe high or even sort of high normal, but T3 is low. So we know that you're not converting it well, which is very, very simple, right? We just don't teach this in school. And then, of course, your tissues, in order to respond, you need plenty of vitamin A and zinc and exercise. And you're not going to get this by taking vitamin A capsules. You're going to get this through cod liver oil and all of nature's multivitamins when you're in my practice. The one that people don't talk about is actually exercise. Building muscle will improve your ability to respond to thyroid hormone. The problem is if you're already hypothyroid, you have this thing going on, you don't have the motivation, you're really, really tired, you don't want to exercise, and you may actually be overweight and it hurts your body. So this is just a part of the story. We have to consider the person's entire experience when we start to talk about helping them fix their thyroid. But exercise definitely is important. And if anti-TPO antibodies are present, in pregnancy, you can start an autoimmune protocol. But I would honestly just say, let's just get you through pregnancy, and then let's get you on a GAPS diet, Wahls protocol, something like that. When we know that there are anti-TPO antibodies, we also know that they're associated with abnormal rises in HCG early in pregnancy. And when you're struggling with fertility in the presence of these anti-TPO antibodies, we know that there's an impact on fertility, but we don't know exactly why. We think maybe the immune system is implicated, implantation issues, or just abnormal placental development. They've all been suggested. I've included plenty of papers for you to dig deeper if you'd like. And the one thing I haven't really mentioned is this iodine thing. You know, we've been told that we have plenty of iodine. In the lesson on micronutrients, we'll talk a little bit more about that and how we can actually use some of these values here as a means of, like reverse T3, for example. That and armor thyroid and plenty of iodine are actually really, really, really beneficial to pregnancy, despite what the doctors and whatnot say. So we'll be getting that into that in another lesson, but now you know more about the thyroid than most healthcare practitioners.